They tend to grow faster. They need to be treated, and that's not over-treatment.
Êtes-vous d'avis qu'on a surdiagnostiqué le surdiagnostic dans les études?
Do you think that overdiagnosis has been sort of exaggerated in these studies? Dr. Gordon?
There is confusion between overdiagnosis and what a false positive would be. So the term false positive is incorrectly used by the task force. It's pejorative to refer to something abnormal on a mammogram that needs additional tests. 95% of those turn out to be negative, and the patient is reassured that everything's fine. And there's a big difference between that, which is not a cancer, and overdiagnosis, which is. But overdiagnosis, as I said, is not a reason to deny screening to younger women. It's not even a reason to deny screening to older women unless they're very sick. As long as a woman is healthy with a life expectancy of 10 years, then it's reasonable to offer her screening, because if we can find a small cancer, sometimes they can be treated very easily, sometimes even just with a hormonal medication, or sometimes just a small operation and not do all the other stuff like radiation and chemotherapy. So that's when it's in the hands of the doctors who are treating her to use their skill to decide how much treatment to offer her.
Le groupe de travail américain
The American Task Force on Preventative Measures recommends that we can screen as of age 40 to save lives. And they even indicate that we might be able to avoid 19% reduction, or guarantee 19% reduction in mortalities. So how can you explain the differential between the Canadian recommendations and the American conclusions?
First of all, the mortality reduction that's possible with screening depends on what kinds of studies you look at. And there's one kind of research called a randomized trial, where you have a control group and a study group, and then there's observational data. So screening has been underway in Canada since 1988, and we know that from observational data, not randomized trial data, that women in the 40s are 44% less likely to die of breast cancer if they have screening. If you rely just on the randomized trials, which are now 40 to 60 years old, they were done at a time when mammograms were X-ray film that we read on a light box. Now they're done digitally on computers with lots of enhancements that make them more accurate. But if you look just at the randomized trials, the mortality reduction was only between 15 and 20%. And the task force did this time include observational studies in addition to the randomized trials, but using the grade system you heard about earlier. What they did is they prioritized the older studies and they downgraded the importance of the observational studies. In fact, if you look at all the observational studies, not just the Canadian one, you'll find that the mortality reduction from mammography alone is in the range of 53% fewer deaths. And yet, because of the task force's overemphasis on anxiety from recalls and overdiagnosis, they concluded that the harms of screening outweigh the benefits.
Thank you, Dr. Gordon. Merci, Monsieur Thériault. Next.
Thank you, Mr. Thériault. Mr. Julian, 6 minutes.
Thank you, Mr. Chair, and thank you to our witnesses. I am looking at the Appendix A summary of the Canadian Task Force on Preventive Healthcare's finding on benefit and harms of breast cancer screening. And I see a chilling absence of empathy. When you look at their own figures, they show that screening 1,000 people ages 40 to 49 prevents 1 breast cancer death. And no screening means that 2 people will die from breast cancer. In other words, the number of people per 1,000 who die from breast cancer would be cut in half. And when you think of the number of Canadian women, because we're not talking about 1,000 Canadian women, but 2.5 million in that age group, we're talking about saving, just from a rough calculation, over 3,000 lives. That's more than the number of people who died in the World Trade Center attacks. So I simply don't understand this chilling absence of empathy, that you would have a task force that could put out these recommendations, knowing that what they're doing is sentencing 3,000 Canadian women to death. I wanted to start with you, Dr. Apobu, and I thank all our witnesses for their testimony today. Does that sound right to you, that the number of lives that could be saved if these task force recommendations were simply set aside and we started screening at 40?
Well, that's a 10-year
Yes.
part. So yes, over the 10 years, absolutely. In fact, the modeling calculations are sort of between 400 and 600 per year. We talk about that being, if you can imagine a jumbo jet full of women going down every year based on the guideline recommendations not to screen. So you're absolutely right. I think there's an emphasis on using absolute numbers only from the task force. And it actually states that they recommend only using absolute numbers. So not saying, you'd save 50% of patients, or if I got breast cancer, I'd be 50% less likely to die if I was screening regularly. They don't want us to say it that way. They want to say it as 1 in 1,000 because it makes it seem like a much smaller number. And frankly, that's a manipulation technique, in my opinion. And it is a well-known manipulation technique to try to control the narrative by controlling the way information is delivered. I think both types of numbers should be used. In fact, I think more than those two types of numbers should be used. But you're absolutely right. There is for an individual woman who gets breast cancer, and it's very common, as we know, for an individual woman who gets breast cancer, the benefit of mammography is huge. If you look at 1,000, most people don't get it. So, you can minimize it by talking about absolute numbers. But if you are that woman who gets it, it makes a huge difference to you. And so it's just playing roulette not to screen. You're just hoping you don't get breast cancer. But if you do, you missed your opportunity.
I thank you for your answer. I mean, I just do not understand how any person could sign what is a death warrant for thousands of Canadian women with such alacrity, without any feeling at all. I know, because and all the witnesses have been very clear about this, the primary people that are impacted are Indigenous, Black, Asian, Filipina, Hispanic women. Is it systemic racism driving this? Because there is absolutely no justification for these recommendations when they know that thousands of Canadian women die as a result of these recommendations. So what is it? Is it systemic racism that is contributing to them putting forward recommendations that are a death warrant for so many Canadian women? I mean,
I'm reluctant to use the word racism, but sometimes you have to call a spade, and there is a systematic form of racism involved in overweighting these ancient RCTs that were performed on 98% white women. When you put those at the top of the evidence hierarchy, or the top of the pyramid, you are systematically leaving out every other race. And women who are white have a peak in breast cancer in their 50s to 60s. Women every other race that's not white gets their peak in the 40s. And in this question, we are specifically focused on this question of women screening in their 40s, and every race other than white has been excluded in their highest level of evidence. So yes, there's a systematic form of racism there. I was dismayed to see in the guideline that they acknowledge that there is a higher mortality in Black women. Black women get a slightly lower chance of getting breast cancer, but when they do, they're 40% more likely to die of breast cancer. And they acknowledge that, but put them in the average risk category, which is the category where they don't get screened in the 40s, or there's no strong recommendation for them to screen in the 40s. And so you've got this double whammy of people being more likely to die if they get breast cancer, and being in a group that is under investigated, studied, and so you've got this, as you said, systematic form of racism. I don't call it personal racism. I'm sure there's no intent to be racist, but if you disregard these racial imbalances in the research, then you have, entered systematic racism.
Thank you, Mr. Julian. Thank you, Dr. Apovo. Next, Ms. Vecchio, please, for 5 minutes.
Thank you very much, Chair. And actually, I just want to go back to Dr. Apovo. We know that many Canadians don't have doctors. I hear it's about 25% here just in the city of Ottawa, from what I understand. So could you help me, from the time a woman goes to her, if she has a GP, what is it that ignites somebody getting something done? Do they have to ask for it? Must there be a referral? Is there a screening where they actually look at the family history? What does screening really look like at stage 1?
Varies from province to province. So, for example, in Dr. Gordon's province of BC, women in their 40s don't need a requisition to screen. They can go and screen, but they're not necessarily encouraged to screen. So, whereas there's probably, if it's similar to Alberta, you've got about 60% of women in the target age group, so 50 and up. About 60% of those women will screen. In the 40 to 49 age group, about 20% of those women will screen. They're allowed to self-refer, but their doctors don't push them to do it. And their doctors don't, and when I say push, I mean encourage them, have the discussion, or just say, you should do this if you want. And but in other provinces where I think in Ontario you have to have a requisition to screen. In Alberta you do at 40 as well if you want to screen. And so it requires the family doctor to be motivated to want to screen that patient. If the family doctors take strong, very often, not all of them, but they take strong leadership from the task force. So if the task force is saying don't screen, the doctor is going to say don't screen. And time after time, and I work with a patient engagement group for the Canadian Society of Breast Imaging, several, if not most of the patients on the panel had asked for a screening mammogram at 40 and were told, no, you don't need it. The task force says you don't need it. And then within a few years showed up with a late-stage cancer.
I want to ask specifically because we know that in certain sections, so looking at a woman who has not bared a child or has not gone through a full pregnancy, that may be one of the reasons or what may be one of the screening. To me, it just seems so simple for stage 1. You sit there and think, you haven't had a child yet or you haven't nursed, perhaps screening before 40 or screening after 40 would make sense. And that's why I'm thinking it could be such a simple thing if you're just being able to go through it at the very step, because we know of the full-term pregnancies. Now, you said, I believe it was 85%, maybe it could have been Dr. Gordon, 85% of women do not have a history in their family of breast cancer. So when we're looking at trying to do these testing, what kind of things would they be looking at a blood test for screening, or would they be looking at a genetic issue?
Is that everybody screens at 40 because your biggest risk is being female. And then the second biggest risk is getting older. So it's very difficult to predict. There are some people you have a better chance of predicting if they've got a very strong family history, if they've had radiation to the chest before 30. There are some people you're going to have to work harder with those patients and get them into MRI and dig a little deeper, make sure you really screen them hard. But the average woman walking around without a family history is still at risk for breast cancer. And because that is the vast majority of women, that is also the vast majority of breast cancers.
Thank you so much. I'm going to go to Dr. Nadler because to me, all of the work you've done here today, this is what we're questioning, saying, look at these guidelines. Not everybody agrees with them. So I want to come back to you and ask you specifically, is there anything that is done when you're talking about this, knowing, for instance, if a person hasn't had a child, is there something that would initiate some sort of screening for anybody under the age of 50 if they've not had yet a child?
The task force recommendations say that any woman who is 40 is eligible for a mammogram as long as she is informed, and actually say if she's informed and she would like a mammogram starting at 40, she ought to have one. The task force does not control access. And so if across Canada we need to open up APSEX, then The task force guidelines would be fine with that, so
I
long as
appreciate that.
women are informed.
And I absolutely
Yeah.
appreciate that. Dr. Nadler, we know here, though, in Ontario, for instance, you would need to have some sort of referral. So what happens?
Not
in
anymore as of the fall of this year.
And are there
in
any
2024.
Are there any provinces that you don't need a referral for, or are they all are referral free now, that you can go directly and have breast screening?
I believe there are still 2 or 3 that don't require referrals, but that could be changed. This is not the mandate of the task force to control access to care.
Oh, and
All
I
the task
absolutely-
force
I
is
absolutely
asking
understand.
Is that women be informed.
Yeah. So my
for
question.
example, somebody meant, yeah, sorry, go ahead.
No, I absolutely agree with you. So on informing people, what does that education look like then? You only have 4 seconds, I'm sorry, but what does education look like if we're saying guidelines are somewhat different?
Do you want me to answer or is there no time?
I don't know if she has time.
Yes, please, a brief answer.
Thank you. So all of the best available evidence on communication does suggest to communicate in absolute numbers. For example, there was a scare many years ago where we thought that the oral contraceptive pill, quote, doubled or increased the risk of a blood clot by 100%, but really again took it from about 1 in 7,000 to 2 in 7,000. I don't think we would ask family doctors to use that 100% increase in blood clots from a birth control pill. We would ask them to give the absolute numbers so that women can make their own informed choice. And whatever choice they make about screening, informed in absolute numbers, should be respected. And however the access wants to be for that, the task force doesn't mind, so long as a woman is informed.
Thank you, Dr. Nadler. Next, we're over to the Liberals, Madame Brière. And I understand you're going to be sharing your time with Ms. Sidhu. You have the floor, Madame Brière.
Thank you. Thank you, Mr. Chair. Thank you to all our witnesses. Dr. Gordon, le comité, est-ce que vous êtes là? Parce qu'on...
Dr. Gordon, can you hear me, Dr. Gordon? Yes. The expert committee said it's not because there are a greater number of cancers that one should diagnose, that you have to do it at a higher rate, but we should ask, why are there more cancers? This should be examined, I think, a lot more closely and perhaps find out why they are more numerous.
We're asking, why is breast cancer getting more common in younger women? And I don't think anybody knows the answer. One that was proposed that seems to make sense to me was, especially during the pandemic, there was greater consumption of alcohol. And we know that alcohol is a carcinogen and related to breast cancer risk as well as risks of other cancers. But just as, for example, we don't know why are women starting to menstruate younger. We know that lifetime exposure to estrogen is a risk factor for breast cancer. And women who start their periods younger and go through menopause later are at a higher risk for breast cancer. And we've certainly seen the age of onset of periods has gotten younger. It's not uncommon for girls as young as 9 to get their periods now, and it used to be 12 to 13 was the commonest average. I've not an expert in this subject, but I've read that maybe it's because our mothers didn't smoke and drink during the girls who are young now. Women my age hopefully didn't smoke and drink during their pregnancy like our mothers did, and they're much better nourished. And maybe that's why they're starting their periods earlier, and maybe that's contributing to increasing rates of breast cancer. But there's a bunch of theories out there. At the end of the day, I don't think anybody knows really why it's happening.
Thank you, merci. Dr. Apovo.
Dr. Apovo, we know that as of 40 years of age, women who have been advised of the information and that it's suggested they should have a diagnostic. But we know in Quebec, it's not, or in Canada, not every woman has a doctor. Do you think that this is an obstacle to access to diagnosis?
If not having a doctor is an obstacle to access. Absolutely. especially in provinces where you need a requisition to get the screening mammogram. So in Alberta, fortunately, we've moved it down to 45, where they actually get invited and can self-refer at 45. But if you want to get in at 40, you need a requisition at least for that first. And if you don't have a doctor, or if your doctor believes the task force and does not want to write a requisition, there's a big barrier right there. And so, yes, that's a huge barrier for a lot of women.
Okay.
Thank you.
Sidhu? You have
Just
just
to
under 2
clarify,
minutes,
if
Ms.
that
Sidhu.
family doctor followed the guidelines, then they should refer for screening. So
Thank you.
guideline care is to respect a woman's choice.
Thank you, all the witnesses. And I certainly would like to share the concerns about the finding of the task force. And I'm glad that our witnesses are here with us, provide more clarity. I would also like to follow up my friend Ms. Vacu's question. Dr. Gordon, we can start with you, but anyway, witness to welcome to add their feedback. Earlier, we heard about the importance of primary care physician and their referral. Could the witnesses talk to this committee about the difference in the outreach to women across provinces and territories to inform them the importance of screening, the education campaign? I mean, are there letters being sent out? Is there a notification system? Help us to understand.
Every province does its own thing. When our screening program in British Columbia was the first in Canada in 1988, and when we started, all women got a letter of invitation on their 40th birthday. That has and women were allowed to attend annually, starting at 40, all through, and then it's gradually deteriorated over the years. We're striving for mediocrity instead of being the leaders now in BC, and now there is no letter, and so. If a woman happens to have seen something in a woman's magazine and she asks her doctor, it will depend greatly on what her doctor says. Now, a woman in BC does not need a requisition. She can self-refer as long as she has the name of a physician to give. And sadly, only 25% of eligible women in the 40s are having screening in British Columbia. We know of examples, and because I volunteer with Dense Breast Canada, which also it deals not just with dense breast, but in trying to get equitable access to screening across the country, we know of so many cases, as you heard from Dr. Apavu, where a woman asked, even begged for a requisition, and her family doctor said, no, that's not what we do here. You don't need one until you're 50. And I give credit to the task force, as you've heard from Dr. Nadler. They have changed it a bit this year. They still say they don't recommend it, but they've made it much more clear from what I've read so far that if the patient wants it, she should have it, and the doctor should give her a requisition. That was not as clear when the 2018 guidelines came out. It was in the fine print further down in the article. But we know of even patients in British Columbia where they don't need a requisition. If a woman asks her family doctor, she might be told, no, don't bother till you're 50.
Thank you, Dr. Gordon. I'm sorry, Dr. Nadler, we're well past time. Hopefully somebody will come back to this topic. Souhaitez le tour de M. Thériault pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. Thank you. In the research project that you participated in, and the report was published in 2022, that the obstacles to individualized risk to breast cancer, you have to know what are the various conditions, and they had very difficult time in classifying the risk factors, ethnic origin, family history, etc. Many doctors didn't have any capacity to arrive at a complete analysis, close quote. Now, systematic diagnosis by mammography, women should, in fact, receive the information as to the results in order to take a decision, make their decision according to their values. Do you think that this ignorance on the part of doctors, as indicated in your report, should confound the decision made by a woman not having access?
Are you addressing me?
Dr. Nadler.
Dr. Nadler.
Thank you. It's important to note that a primary care provider can engage in shared decision-making with a woman without knowing the exact lifetime risk that she has. That being said, it is important for a family doctor to assess a woman's risk factors, I agree with all the other experts here, because that primary care provider needs to know if that woman is even at average risk. If they're at average risk, these guidelines apply to them, and the guidelines say she should have a choice. If the woman is at higher than average risk, then it is a completely separate screening recommendation that doesn't even fit within these guidelines. It is correct that some primary care physicians could use extra support in terms of learning about risk factors and calculating lifetime risk. And separately, that is outside of the scope of these guidelines. Some of the work I do is in helping to create toolkits and to help support primary care providers to do this. But I think first and foremost, the most important thing is one can still have a shared care discussion if one has determined that the woman is of average or slightly above average risk, which the task force does clearly define also in this updated guideline, which is an improvement from the 2018 guidelines.
Thank you, Dr. Nadler. Merci, Ms. Thériault. Next, Mr. Julian, please, for 2.5 minutes.
Thank you very much, Mr. Chair, and I appreciate all our witnesses being here. Unfortunately, because of the time constraints, at the end of my 2.5 minutes, I'll be moving a motion to adjourn. I wanted to come back to Dr. Apovu and then ask Dr. Nadler and Dr. Gordon the same question. You mentioned in your testimony, Dr. Apovu, that it was important to look to dismantle and rebuild the task force. And very clearly, the task force is not responding certainly to the needs of Canadian women, certainly to the needs of racialized women in the healthcare system. How do you feel? How important is it to dismantle and rebuild, and what should be the steps to actually accomplish that?
Thank you for asking that. Quickly, one of the reasons that I think that there should be complete dismantling and rebuilding is because this problem is not just isolated to breast. Breast is sort of the tip of the iceberg. Multiple other screening guidelines in cancer and non-cancer fields have similar reactions from experts and are similarly concerning. As one gastroenterologist told me regarding the colorectal screening guidelines in an email, he said, people are going to die. And unfortunately, there is no accountability structure. There's no way, because it's arm's length, there's no way to fix the guidelines that are wrong. And there's no way to, there's no way to update any sooner than they feel like updating. So we've got guidelines sitting there that are very outdated, dating back to 2012, 2013, and so ultimately we can make any fix to any individual guideline that we want, but the problem will happen again and again and again because the problem is fundamental to the structure and the accountability of the task force. And I think ultimately there are many national and international guidelines that are well accepted. Experts in the fields can guide you to use a better guideline in the interim while we restructure the guideline. The task force.
Thank you.
Point of
My
order.
time has expired, so I'll
Point of
move a
order.
motion to adjourn.
Point of order just before you moved your motion, Mr. Julian. So go ahead with your point of order, Ms. Goodridge, and then we're going to deal with the motion.
Thank you, Mr. Chair, and I appreciate the fact that the member wants to end our meeting early. Women's health is something that is understudied greatly in this country. We have an opportunity here with witnesses. We have time for another
Ms.
round
Goodridge,
of questions, and this is absolutely inappropriate.
That is absolutely not a point of order, and a motion to adjourn is not debatable, which is what you were trying to do through the back door. Is it the will of the committee to adjourn the meeting? All those in favor of
I
adjournment?
requested recorded division.
Okay, thank you.
Recorded division on the motion to adjourn. Dr. Hanley.
No.
Ms. Kaibega.
No.
Madame Brière.
No.
Ms. Gainey.
No.
Ms. Sidhu.
No.
Ms. Vecchio. Mr. Moore.
No.
Ms. Goodridge.
No.
Dr. Kitchen.
No.
Mr. Thériault.
No.
Mr. Julian.
Thank you, Mr. Chair. Yes.
10 nays, 1 yay.
So next up on the speakers list is Ms. Ms. Roberts. No, Ms. Goodrich, please, for 5 minutes.
Thank you, Mr. Chair. It's interesting, as I read through the guidelines, I remember my initial anticipation as I read through them was how it considered that women did not have the ability to make decisions, and that somehow the feeling of anxiety somehow trumped living. And as someone who has both dealt with the anxiety of being sent out of my community to get additional testing as a result of dense breasts, the anxiety that really keeps me up at night is the anxiety of wondering whether I will live to see my children grow up, not the anxiety surrounding a test. So my question to you, Ms. Gordon, or Dr. Gordon, sorry, what advice would you have if you could draft new screening guidelines for Canada?
Well, first of all, I need to explain that it is well known that a percentage of women, perhaps around 10 plus or minus, are going to be recalled. And it is known that women are much less anxious if they're prepared ahead of time, if they're told that this could happen. It's most likely to happen on their first screening mammogram because there are no priors to compare with. So women need to be told, just as they need to be informed about the possibility of overdiagnosis, just so they're prepared. Now, my wish list, I'll start with what Dr. Apavu said. All women should be assessed for risk early in life, perhaps at around the age of 30. Then all average risk women who don't need to be screened younger because of increased risk would be able to start at 40. They should be able to self-refer without a requisition from their physician. They should be able to go annually, at least when they're premenopausal, because that's when the hormones cause breast cancers to grow faster. Ideally annually until they don't have 10 years of life expectancy less. And we have loads of data to show that's how you save the most lives, the most years of life, and that how you get to offer the least aggressive therapy. Women should be told after they have their screening mammogram what their breast density is. We've only just now, after 7 years of lobbying, finally got pretty much every province and territory on board telling women their breast density. Up until 2018, no woman in Canada was being told their breast density. And why? Because we were told, because we're going to make them anxious. You know, when a man has high blood pressure, we tell them they have high blood pressure because it's a risk, and they need to know as much information about their own health. Women deserve to know their breast density because of the two associated risks. Then from there, any woman with category C or D, those are the women with dense breasts, should have access to supplemental screening, because when a woman has dense breasts, there's a risk that her cancer might not be seen on her mammogram, and that supplemental screening with either ultrasound or MRI can find many of those cancers. And then finally, women should be able to continue having screening beyond age 74 until her life expectancy is less than 10 years. And for most women, that's age 80. At age 75, according to Stats Canada, a healthy woman has a life expectancy of 13 years, and at age 80, it's 10 years. So that's my wish list for screening.
Thank you. Thank you. I appreciate that you brought up the fact of extending it past 74. I actually had a number of women, after I brought forward this, bring that to my attention, that was something that was a constraint to them, especially when they were healthy. So to Dr. Apavu, we have an audience here today. We have people that are tuning in, paying attention to this health committee meeting. What recommendation would you have to women listening? And I've got about 30 seconds.
My recommendation is start screening at 40. If you need a requisition from your family doctor, and your family doctor is reluctant to write the requisition, and I know that now the task force guideline actually states that the woman should be allowed to have screening if she wants to. I know a lot of doctors who talk their patients out of it because they fully believe that overdiagnosis and anxiety, all these paternalistic ideas about why women shouldn't screen, they talk their patients out of it. And go in and don't let yourself be talked out of it. Make sure you start at 40 and go every year, as Dr. Gordon says, during premenopause.
Thank you. And now I would like to move a motion, Mr. Chair, that in relation to the committee's order of reference of Wednesday, May 29th, 2024, concerning Bill C-368, an act to amend the Food and Drugs Act, Natural Health Products, A, the sponsor be invited to appear during the first hour of the committee's meeting on Thursday, June 13th, 2024. B, other witnesses be proposed by the parties appear during the second hour of the committee's meeting on Thursday, June 13th, and the first hour of the committee's meeting on Monday, June 17th, 2024, and that all amendments be submitted to the clerk by no later than 4 p.m. on Friday, June 14th, 2024. D, clause by clause consideration of the bill be taken up during the second hour of the committee's meeting on Monday, June 17th, provided that at the later of the conclusion of the second hour or 5:30 that day, if the committee has not completed clause by clause consideration, all remaining amendments submitted to the committee shall be deemed moved, and each recognized party shall be allotted no more than 5 minutes for each of the remaining amendments and clauses, and the committee shall not adjourn until it is disposed of the bill, and E, the chair and the clerk be instructed to seek the House resources necessary to implement the terms of this motion. And I have a bilingual copy that I can circulate to members of the committee. Thank you, Mr. Chair.
Okay, feel free to circulate it. However, the motion that you just presented does not touch the issue at hand, and the committee has not been provided with 48 hours notice. So I therefore rule it out of order.
Mr. Chair, it is effectively a slight amendment to the motion that was put on notice on June 3rd by my colleague, Dr. Ellis, just to update the dates. Otherwise, it is identical. So if you would prefer, I could amend the original motion, but I thought this was cleaner and simpler.
Well, your only option now is to challenge the chair, because there's two issues. Number one, if you were moving Dr. Ellis's motion, you couldn't because you aren't Dr. Ellis. And two, the motion that you moved is not identical, requires 48 hours notice, which hasn't been given. So the motion is out of order, and unless there's a challenge forthcoming, we're going to move to Dr. Hanley, please, for 5 minutes.
Then I will ask for unanimous consent of the committee to move the motion.
Does Ms. Goodrich have unanimous consent to move that motion that has not been put on notice? There is no unanimous consent. Dr. Hanley, please, for 5 minutes.
Thank you. I want to thank all the witnesses, and I want to thank Ms. Goodrich for bringing this study into a priority lineup. It is an extremely important study and very timely. Dr. Gordon, you're a very compelling witness, I have to say. I think most of my 5 minutes will be probably devoted to just drilling down on a few issues. I wonder, can you talk to me about interval cancers and the relative importance? Because, having been versed in this over many years, the sort of, you might say, traditional thinking is that aggressive cancers do not lend themselves to screening because almost by definition they appear between screening intervals, and that often the younger the woman, the more aggressive the cancer. And this applies to other types of cancers, of course, which is one of maybe the limitations of screening. But maybe you could clarify what you think of that based on what we know today, especially with the technology that we have today. Is this becoming a more outdated phenomenon?
So let me just define for the others. An interval cancer is one that turns up after a woman's last mammogram was negative, and they're usually found as a lump. And interval cancers are more often the aggressive ones, the HER2 positive and so on, the rapidly growing cancers. And they often present larger, already spread to the lymph nodes than screen-detected cancers, and they do have a worse prognosis. But there's two categories of interval cancers. The ones we just mentioned, the rapidly growing cancers that even if you look at her recent mammogram and she didn't have dense breasts and she had the easy kind of mammogram to read, it really wasn't there, and it developed so fast that, let's say her mammogram was negative and 6 months later, you do another mammogram when she shows up with this lump. And oh my goodness, there's a lump that's easy to see on her mammogram. That's one kind, the kind that just grew so fast that they weren't there on the mammogram. But the other kind of interval cancer is the one that was there when she had her mammogram, but it was hidden in her normal dense tissue. So breast density refers to the amount of breast tissue, glandular and fibrous tissue, let's just call it breast tissue, compared to fat. All women have both in their breasts, but the proportions vary tremendously. Some women's breasts are all fat, and then some have a little bit of dense tissue, some have more, and then there's the highest category of dense tissue where there's hardly any fat and it's all dense tissue. And the reason that's important is that normal breast tissue, dense tissue on a mammogram, is white and fat is black. And all lumps, including cancers, are white. So if a woman has a fatty breast, it's a dark gray or black looking mammogram, and even the smallest little white cancer jumps out at you like the star in the sky. If a woman has a very dense breast and it's all white, you're going to miss even a big cancer. And in fact, 50% of cancers are missed in the densest tissue. I'm going to let you get a word in.
I only have 2 minutes or less than 2 minutes left, but I appreciate the fulsome explanation. And I want to just focus on the U.S. And the way that the recommendations are now in the U.S. Preventive Task Force versus Canada. Now, you do acknowledge that that we have included observational studies in the Canadian guidelines for the first time, but also that they are weighted differently from clinical trials. But there's almost a time consideration because clinical trials, almost by definition, are older. But the RCT has always been the gold standard of trials. Anyway, all to get to the point of, do you see that there is a process that is happening differently in the U.S. Versus Canada? And should we be looking at processes potentially different to emulate the U.S.? Also noting that the U.K. has not changed from 50. As far as I know, the U.S. is perhaps one of the first to go to include the 40 as
So what the U.S. did differently than Canada is that they took a greater weight of the fact that of the data showing an increasing incidence in younger women and the incidence of breast cancer in racialized women that the Canadians didn't. But the Americans didn't get it perfect either. They're only saying to screen every 2 years. So and they clearly don't weight the harms to the extent that our task force does.
Dr. Nader, I wonder, we won't have time for you to speak to this, but I would, if you're able to table a response to that and to the sort of the difference between the U.S. approach and the Canadian approach, I think that would be very useful. Because am I out of time, or do I have?
You could.
Okay.
Dr. Nedler, were you going to give her a chance to?
Yes.
Okay. Yeah, please take 30 seconds to offer your perspective, and if that's not enough, feel free to follow up in writing.
Thank you. The incidence in Canada has changed differently than the incidence in the United States, which may be one reason. Secondly, Dr. Paula Gordon explained the difference in two types of interval cancers, and it's important to understand that exactly as Dr. Gordon said, that's why screening doesn't help for some interval cancers because the more aggressive ones appear between screens. Although screening does help for some, it doesn't help for all. Another important thing about interval cancers or detecting cancer early is that we don't necessarily know that screening is going to change the outcomes. This is something called length time bias. A more slowly growing cancer is going to sit and wait and not present as a lump until a screen. A more aggressive cancer is going to show up in between screens. And so obviously when we look back at retrospective studies, it looks like screening catches all the very slow growing cancers. And it looks like all the fast growing ones are in people that don't have screening. But that's because they're fast and they show up as interval cancers. That's called length time bias. And it's a very important bias. We don't dismiss studies because of it, but we always have to think that that bias is there. And the task force has to look at all of that data as systematically and as methodically as possible. Finally, just one point to the U.S. They actually acknowledge in their guidelines that that recommendation doesn't actually improve EDI or equity and diversity. They actually say that in their guidelines, that starting everybody at 40 doesn't actually improve the disparities.
Thank you, Dr.
So
Nadler.
we all call for more research in that area.
And I'm sorry, Dr. Gordon, we have reached...
Mr. Chair, perhaps Dr. Gordon could submit her
Yes.
reply.
In fact, and this
Could we
goes...
get unanimous consent to get an answer from Dr. Gordon to that?
Okay, everybody okay to extend it? Dr. Gordon, go ahead. Everybody wants to hear from you.
I'll be quick. Yes, what Dr. Nadler says is true, but we do know that the size and the nodal status still matter even for aggressive tumors. In fact, sometimes it matters even more. And as I said, the 5-year survival rate for stage 1 triple negative cancer is 96%, and stage 3 is 47%. We also use modeling. It's not all about anecdotal cases of some women didn't benefit. It's true, not all women will benefit to the same extent as others. But if you don't screen, you don't find the cancer in the first place to know whether it is high grade or not.
I'd like to thank all of our witnesses for being with us here today and being so patient as we worked through several challenges that interrupted and delayed your testimony. Your expertise is evident, and we are extremely grateful that you were here with us to kick off this study and